Tell me what y'all want to know. That way I'll hit the points at the end. Any questions about aneurysm before I tell you all about them?
What about the evidence for the HHH therapy? Just the different things you do, the rationale for like the Decadron, the different orders and everything.
All right.
If you had time, would you be willing to talk about AVMs at all with embolization?
AVMs.
Pressure management?
Okay. Okay.
What makes you decide to put somebody on vasospasm protocol versus not protocol?
Okay.
Coiling versus clipping.
Okay.
Secured versus unsecured?
Okay. All right. Okay. So an aneurysm is just a weak spot in the artery. So about the 4th week of fetal life, you start differentiating your arteries from your veins, and at that point, there are sometimes weaknesses in the muscular layer of the arteries, and those are where aneurysms come from. They always come from where an artery branches, so they don't ever come from the straight part. Where an artery branches, at that point, the blood is sort of shooting right at that, and it causes a pressure head, and eventually that'll get big. So most people have their aneurysms from the time they're born. Aneurysms just don't occur. Occasionally they do. Sometimes with trauma, you can tear the artery and it can have an aneurysm. That's called a pseudoaneurysm. Very occasionally, people with tumors can have metastasis to the blood vessel and cause an aneurysm. I don't think I've ever seen one, but they say it can happen. About 4% of the population has an aneurysm. So just in the normal, everybody walking around, about 4% of people have them, but about only half of those will ever have a rupture. So the chance of you rupturing your aneurysm increases as you grow older. Of those that have a rupture, 50% of those won't get to the hospital. They'll be dead. So those are, if you have an aneurysm, it may not ever cause you any problems, but if it does, it can cause really big problems. If your mother or your brothers or a first order relative has an aneurysm, then your chance of having an aneurysm goes up to about 17%. So there is a familial component to it. So that's why we tell people in the office, if their mother had one, or if they have one and they have siblings, we get them to get a screening MRA or CTA because their risk of aneurysm is higher just because it's in the family. So at y'all's point, the person's already come in with an aneurysm that's ruptured, and so the next thing to do is decide what to do about it. So before we start treating anything, there's a scale called a Hunt and Hess scale. That's it's like a Glasgow Coma scale. It sort of gives us an idea about what we're dealing with. And that scale goes all the way from 0, which is a aneurysm that sort of got found incidentally. The aneurysm hasn't ruptured, the person had an MRI or an arteriogram for some other reason, and just by accident was found to have an aneurysm. Obviously that's the best one to have, is a grade 0. And then it goes all the way up to 5, or 5 being the patient's comatose, not moving, and essentially dead. Most aneurysms come in, they're Hunt and Hess grade 3, and that's just any kind of decreased level of consciousness. Y'all come sit down. Any kind of decreased level of consciousness, like if you're talking to the patient and the patient's just kind of continually going to sleep before you have to shake them, that's a 3. That's what most people are. And that gives us some indication about what their survival is going to be, just like a Glasgow Coma Scale. It's not perfect, but it sort of gives you some outlook about it, what you're dealing with. So the next, after we sort of put the patient in the unit, the next thing to do is decide what their aneurysm is, where it is, and then we can do then we can go to this, whether or not we're going to clip it or coil it or do anything with it. So still the gold standard is the arteriogram. CTA and MRA are not. I mean, they can miss things because it's a computer operator generated picture. All they do is they get this big volume of information and then just turn the contrast up and down to get the blood vessels that they want to see. The problem is that when they turn it up and down, like they may miss little ones. Actually, they may miss big ones when they do that. So it's a good screening test, but it's definitely not 100% accurate. That's what the arteriogram still we have to tell us exactly what we're dealing with. So the difference in treatment, if we're going to decide to clip or coil it, depends on 2 or 3 things. So let's say we'll do clip and coil. So the first thing is the number of aneurysms. If there's like Miss Hill that's in the unit right now, she's got one on one side that ruptured that we had to go in because she was crashing in the ER. She's got one big one on one side that bled, and then she's got 2 other ones on the other side. So the number of aneurysms, if it's not an emergent situation, to save the patient a craniotomy on both sides, you can coil those because you're saving the patient an operation. So the number of them matters. The site matters. Almost all the ophthalmic aneurysms and almost all the basilar aneurysms now will be coiled because the risk with surgery is so much higher with those 2 types of aneurysms than any other aneurysm that this coiling is way safer than an operation. The problem is that both of those aneurysms, the problem with coiling is that you don't cut off the entry to the aneurysm from the blood vessel. You just pack the blood vessel. Let's see. So if this is the aneurysm, there's a hole in the artery where the blood flows up here and curls around, and that's where it ruptures. When you coil an aneurysm, you just fill this space in with coils so that the blood has an obstruction. There's no blood that can get up there. But the problem with these 2 aneurysms is that they're right at the V where the blood hits, like I showed you before, the aneurysms. So there's a big coil mass here where the aneurysm was, but the blood's still beating up against it. And actually it can push that coil mass up and form another aneurysm underneath it. They're working on some other things with the coils to try to close this space, but they don't have that done yet. So even though those 2 definitely should be coiled first because of the risk of the surgery, they also have the highest risk to come back. And then it's really, really hard to take care of them. So it's sort of a sort of juggling act there. Most people would not coil a middle cerebral aneurysm because almost always with a middle cerebral aneurysm, there's little bitty blood vessels coming off the aneurysm. You can't occlude those without causing a stroke. Whereas when we operate on that, we actually see those blood vessels with a microscope and peel them off and push them away so that we can clip just the aneurysm and not those blood vessels. So almost all middle cerebral aneurysms will need an operation. So Ms. Hill has a middle cerebral aneurysm on the other side, so she's very likely going to need another operation. The main thing as far as coiling goes is what size is the neck. So if the neck is this big, there's no way to, what happens is they put the coil in and the coil just wraps back around. There's nothing to hold the coil in there. The best aneurysm is one with a small neck like that. So the coil goes in and then bumps against the side and just keeps coiling in like that. So the neck size makes a difference of if they can coil the aneurysm or not. Now they've got some super tricks now that they put a stent, a wire stent across the hole that has holes in it, like a fence. And they can get the coil to go through the fence, and then it bumps up against it, and then it coils up. But then they can't, then they have a stent in this artery, so the stent can narrow the artery, it can cause a stroke, then the patient has to be on Plavix, so there's a lot of other things that go along with it. But the neck size, if the neck size, the opening is too big, then it's unlikely that that's going to be coiled. What else? That's pretty much it. At first, when we first started coiling aneurysms 20 years ago, we couldn't get to a lot of places. We could get to the very proximal places like on the carotid artery and maybe the tip of the basilar, but we couldn't get out to the middle cerebral, couldn't get out to the way pericallosal, way out distal. But now with catheters, they can pretty much get anywhere. So the position of the aneurysm is not as much as a problem as it used to be. It's really neck size and site. That's really the two main things. So when the patient comes in with a ruptured aneurysm, if they have an ophthalmic or basilar aneurysm, almost always they would be coiled first. Hardly ever would we operate on those people anymore. If they have the most common aneurysms, a posterior communicator or a anterior communicator, then it's just a matter of, well, I guess the other thing down here is their medical condition. You know, then you have to decide if their heart's strong enough for a surgery, because even though you have to go to sleep with a coil, it's not as stressful on the body as a surgery. So if they're medically unstable to go to the operating room, then they would get clipped. Otherwise, because of the chance of recurrence of the aneurysm with a coil, we would almost always clip those. So that's sort of the algorithm we go through when we get them in. Any questions about that? And we're lucky here to have really good interventional people that we talk about every aneurysm. No one makes the decision on their own, so they all listen to me. Okay, so now the aneurysm's ruptured, it's taken care of, either operated or clipped. And essentially that secured and unsecured thing is just if the aneurysm's clipped or not. So what that matters on the protocol, okay, we'll get to that in a second. So now the aneurysm's taken care of, the risk of hemorrhage is gone, because that's the main reason to do the surgery, is to keep it from hemorrhaging again. So that's done, the patient's in the ICU. Now it's a matter of taking care of the effects of the hemorrhage that have already happened. You know, aneurysms can rupture just in the subarachnoid space, so there's no damage to the brain itself, and the blood's all around the brain. Or they can rupture in the brain and have a big clot like Ms. Hill had that we had to take out. When the blood is, let's see, we don't have a model here, but if this is the brain and this is the arachnoid, the blood vessels live in the subarachnoid space. That is the space between the arachnoid and the pia, which is the covering of the brain. So they live in the subarachnoid space. When an aneurysm ruptures, it fills that space up with blood. And the blood vessels hate that. So the main purpose of a patient being in the ICU is to take care of the problems that are going to occur because the patient's already had a hemorrhage. The aneurysm's clipped. We don't have to worry about it bleeding again, so that's not why the patient's in the ICU. What happens is that blood breaks down, just like it does if you have a bruise on your arm and it turns yellow and green, and the blood products break down. When that happens, it releases some substance. We don't really know what it is. Some people think it's hemoglobin, some think it's some other kind of fibrin products. No one really knows what the actual product is, but it's a breakdown product of the blood. And what it does is cause spasm in the blood vessels. Okay, so vasospasm. So it irritates the wall, the muscle of the blood vessel, and just constricts it, and can constrict it all the way to shutting it off. So that's the main purpose of treating the people in the ICU, is to work on that and prevent that. 40 years ago, people would never operate on aneurysms until the patient made it through 3 weeks. So the patient would come in, have an aneurysm rupture, they'd put them in a dark room, wouldn't ever go bother them because apparently they thought any kind of stimulation would increase their risk of hemorrhage. And they would wait for 3 weeks until all the blood sort of went away, and then they would operate on them. Well, about 60% of the people died because of vasospasm. So that's when we started operating on them really early, so we could treat this. That's the main reason people die from aneurysms that make it to the hospital, is because of spasm. So when the patient gets back, that's when we go on the protocol. Okay? So the spasm protocol is meant to take care of your blood pressure, really for your cardiac index. That's really what we're looking at. And it's also looking for fluid balance and less hematocrit. So the H's are hypertension, hematocrit. I did that already. And what's the third one? Hypervolemia. So the three things have been shown to counteract and prevent spasm from really narrowing that blood vessel all the way down and causing a stroke. The thing we're working on with the Swan and everything is to keep their cardiac index, their stroke volume high, to push. Essentially, we're pushing blood through a narrow pipe. I mean, the pipe's supposed to be this big and it's narrowed down, and we're trying to push blood through that. So that's what the blood pressure is, but it's really more than just the blood pressure. It's really a cardiac index, because that encompasses your heart rate and your blood pressure and the systemic vascular resistance and all that, mainly to get blood to go through that blood vessel. The hypervolemia is in the same vein, keeping enough volume in the heart that it can have a good enough cardiac index to pump through there. The hematocrit, we don't do that as much anymore. Theoretically, with a hematocrit of 30, that is the most efficient way that blood cells go through a blood vessel. When blood cells go through a blood vessel, they sort of tumble around. And if your hematocrit's too high, they can get stuck and sludgy, especially in vessels that are spasm. So in the lab, at least, a hematocrit of 30 is what we sort of shoot for as far as the fluid dynamics of a blood corpuscle. That's how it's the most efficient going through a blood vessel. And I don't know if Joyce remembers, but we used to bleed patients to get them down to hematocrit. We,
I don't go back that.
oh, yeah, you do.
I mean,
But I haven't done that long. We used to actually do it. You know, they come in with a crit of 40, and we would actually take blood off of them to get them down to a crit of 30. We don't. It's not. It doesn't really make that much difference. We never saw a significant advantage to that. It didn't hurt the patient, but it didn't really make any big difference. So that part of the Triple H is really not done anymore. It's sort of historic. Now, obviously, if a patient's got polycythemia or some other blood dyscrasia that their crit's 50, well, you know, we probably would do that, but I hadn't done it in I don't know how long, 15 years. But those three things just by themselves do fight the spasm. The majority of patients that we treat with vasospasm can be treated with those things. Occasionally, those don't work by themselves. So the next step would be if we have a patient that's had an aneurysm rupture, they're in the unit. Typically, the worst spasm, if we make a graph, days and what is this going to be? Spasm. Between the 7th and 10th day is really the peak of spasm. So that's why I'm always writing in the chart post-op day, post-bleed day, because the bleed day matters when the spasm is going to happen. Almost always between 7 and 10 days, but it can happen all the way out to 21 days. And so I've even seen it longer, but almost always between 7 and 10 days. And that's why we get the Dopplers on day 4 and day 7 and day 10, because that's what we're looking for. If during that time we get a patient who's in spasm that we know from the Doppler studies, and we're treating them with the protocol, and they get aphasic or they get weak on one side, and we've maxed them out with all the pressors we can use, and they're not getting any better. Well, then the next step is to go to get an angioplasty in specials again. And an angioplasty is just like the heart. It takes a vessel that's in spasm, and they just put a balloon in this spot and just blow it up, and it just opens up the blood vessel again. Amazingly, that doesn't squeeze back down. It stays open because essentially you're sort of mechanically smashing that spasm back to a normal blood vessel, and the inciting episode is already passed, and there's nothing to make it spasm back. So just that mechanical opening can make a patient wake up, just like a stroke, just like they do strokes. I mean, they'll come back and they'll move in their side if you catch them fast enough. So that's why it's real important, especially on that between the 4th and 12th day, but especially 7 to 10, to be really wary of any kind of small neurologic change, you know, pupil or weak or can't talk like she was, or she's more confused, anything like that, especially in that 7th and 10th day, is really a red flag that spasm's coming on, and that we need to really work on getting them maximized on their Triple H therapy, or have to go and have something else done. All right, so there's that. We did that. The only other thing that can come up is hydrocephalus. We rarely see that anymore because typically all that hydrocephalus is just a sort of a blocking of the plumbing of the brain, and the brain makes spinal fluid and stores it in the ventricles, and if something's blocking that, it just goes bigger and bigger, like you've pinched off a hose, and behind it the pressure builds up. Hydrocephalus in a subarachnoid hemorrhage is just from the blood stopping up, just mechanically clotting off the pathway that the fluid flows out. That happens maybe, I I rarely see it happen, but apparently it happens about 15 or 20% of the patients globally. What we do is when we operate, we actually put a drain in. Some people leave the drains in. I don't leave them in, but we actually wash that out so that we can get rid of those early blood products and keep it from clotting off. So I don't remember, I haven't put a shunt in for a subarachnoid hemorrhage patient in I don't know how long, 5 years or something like that. But that's that usually happens late, like a month later or 3 months later or something. But we haven't really seen that much of that. So the main reason that we're keeping people in the ICU for 2 weeks is the spasm. That's why they're here. I know I've had a couple of people that we've kept, actually Mr. Teams that came back in. I mean, we don't know really when he hemorrhaged, but I've had another lady that we knew hemorrhaged, and we sent her home, and 3 weeks from her hemorrhage, maybe even more than 3 weeks, she came back with a weak side and got angioplasty and got better. But the spasm can happen way longer than that. The other treatment that we had for spasm that I didn't write on here was nematope. Let's just put that. So that's a calcium channel blocker. Apparently the research showed that whatever the inciting material was in the blood closed off the calcium channels in the blood vessel wall. And apparently the calcium channels are what make the artery constrict and expand. And so whatever the inciting bilirubin or whatever it is, it stops that up and the vessels just constrict. So 25 years ago, they started using calcium channel blockers, verapamil first, and then something else. And then this was the best one because it didn't affect your blood pressure as much, although it does affect some people. But this blocks that mechanism of the blood causing the vessels to squeeze down. And then, so they did a big study about does it work or not. And apparently, you have to start it within, so let's see, less than 96 hours. So you got to start it within 4 days of the hemorrhage. So people that come in a week out, it's not going to do anything. There's no reason to use it. But if we start it before 96 hours, it doesn't really decrease the number of people that have spasm. It just decreases the effects of the spasm. So we still have to use the HHH therapy to keep them from having spasm, but then the calcium channel blockers prevent the people from having strokes. That's why we use it. And we use it for the 21 days because that's the sort of tail end of the spasm chart. That's why we use it that often. Any questions yet?
On the vasospasm, does the blood have to be in the subarachnoid space, or could it be somewhere else to cause it, or is it only specific when the blood's in the subarachnoid?
It's only in the subarachnoid space. Because when people have like an aneurysm that pokes out into the temporal lobe and they have a big temporal lobe clot, they almost never have spasm because all the blood's in the brain. So yeah, it has to be in the subarachnoid space. There's whatever the chemical is in the blood mixes with the spinal fluid, and that's what causes the problem. So it has to be in the subarachnoid space. If it's in the brain tissue itself, they hardly ever have spasm. And people with the other thing is people with traumatic subarachnoid hemorrhage rarely have spasm. It's really about the blood vessel wall exploding in the aneurysm. Something mixes together, and that's when it happens. So traumatic subarachnoid hemorrhage rarely has spasm too. It's all aneurysmal subarachnoid hemorrhage.
I'm just curious, because sometimes I know that, I have been around a long time, longer than you.
Probably.
I remember. I was just wondering, because, over the years, I've seen us decrease the number of patients that come back in with swans. Sometimes you kind of wait, put the swan in, or maybe it's a different way of approach with different positions or something. At one time, everybody was swan, okay? Pretty much.
Yeah.
Seems like.
So there's a scale of thickness of subarachnoid hemorrhage. I can't remember his name. Anyway, the thicker the amount of blood in the subarachnoid space, the more likely they are to have spasm. I can't remember his name, but anyway.
Fisher,
Yeah, no,
no, it's,
I don't know. Anyway, so typically the patients that have a very tiny amount of subarachnoid hemorrhage, we would wait and see. The other end of the spectrum is a patient that's got sort of minimal cardiac function. We don't want to push them with all the fluid and blood pressure and sort of beat that dead horse, so we sort of wait on those too. Unless they just have a small amount of hemorrhage for me, I would always put a swan in. Now, I know some of the other guys wait to put swans in until they start going in spasm. That's ridiculous. You've lost. Because the swan and the protocol are preemptive. If you wait till it's already happened, you've lost the game. You can't catch up. So that's why you put them in early.
so the TCDs, when you do those, how closely do they correlate? I mean, as far as the clinical outcome and everything? You look at those real carefully.
Well, so the Doppler is just an easier, more non-invasive way to look at the blood vessel. Let's see. So the transcranial Doppler, let's see. The transcranial Doppler is a sort of a window that you can look at the the velocity of the blood in the blood vessel, and also, so there's that velocity number, and then there's also that, you've seen them put the pulsatility number. So the velocity is obviously what that is, how fast the blood's going through the blood vessel. And so they can point the Doppler at the blood vessels and actually make it go to this depth or this depth or this depth, so they can see what blood vessels, and we know sort of what depth the blood vessels are and which way the blood's flowing. You can tell that, so you know what blood vessel you're looking at. So the higher the velocity means the smaller the diameter of the blood vessel. So that's what we're looking at with the velocity to tell us if the vessel's going into spasm. The pulsatility is just how much the vessel's sort of bouncing when the blood goes through that. If the blood vessel's in spasm, the blood vessel is very stiff. I mean, it's like that, and there's no pulsatility, and that's why a high velocity and a low pulsatility is spasm. The other things like low PCO2 can decrease your velocity, ICP can decrease your velocity. There's other things that, depending on the pulsatility and the velocity, what's going on. But yeah, so the Doppler is just an easier, non-invasive way to tell whether or not they're going into spasm. That's why we do them serially, so we can see a trend. It's like taking one blood pressure. If your blood pressure is high one time, that doesn't mean you have hypertension. It's a series of those. So that's why we do a series of them on those specific days. What else were you asking? No, there was something else you said, not about the Doppler. Anyway, okay.
I was saying, the clinical correlation, like.
Oh,
okay,
so it's not perfect. It really depends on people's thickness of their skull and how their blood vessels are angled and stuff like that. So it's not as good as an arteriogram to tell us if they have spasm or not. But for probably 90% of the people, we can get a really good picture about what's going on. You'll see that sometimes they go in there and they're wandering around. They never can get it because it's just the way that people's skulls are made and how their blood vessels are. They just can't get a window to see the blood vessels. But most of them are, you can see it, and it's really about the trend. It's not just the one number. So if we see spasm, then the arteriogram is going to show it. I mean, there's maybe a 10 or 20% false negative that they have spasm, but the Doppler can't see it just because of the anatomy. But it's a good non-invasive way to follow that, so you can have a sort of a, it's going to happen before the patient gets sick, sort of thing. Any other questions about those? Yeah, I'm going to do that. But any other aneurysm questions?
So if they come up, like from the OR, you just have like vasospasm protocol written in the orders, and it's not like the protocol is not exactly checked as far as pressors. Can we just assume that any pressor can be used that's on the protocol if we need it at some point for their blood pressure?
Yeah, I mean, dopamine we used to use. I guess we use that first now, but that gives a lot of tachycardia and cardiac problems. So, yeah, for me it's okay. I mean, I wrote the protocol, but I wrote too many boxes to check. So, dopamine's first, I think. You know, it's just easier to titrate. That's what I'd use first. I guess the top one on the list is what I meant to use first. Is it on there first or dobutamine first? Yeah, I think dopamine's first. So that's what I meant to use first.
Do all that, I think one of the things with the nurses that don't have a lot of experience particularly, it's kind of nice to just have it checked which one.
I know.
They like to check.
I mean,
I know. I put too many boxes in there.
Its priority is who's ever top.
Yeah, whatever's on the top. Yeah, we don't care if you call us. So.
Okay.
But you would rather that they're at least maxed out on all pressors before we stop giving nematote? Because I know some people say, well, it dropped them like 20 to 30, millimeters.
Well, that's when we cut the dose in half and do those other
Okay,
things.
So you still utilize your pressors just for the purpose of giving the nematote.
Depends how long their blood pressure dipped when you give them the nematope, I guess. But they're going to be on, well, maybe they're not. But yeah, I mean, it just depends how long and whether or not they have symptoms from it,
And they rebound back up.
Mm-hmm. So yeah, I probably wouldn't use it just because of that, unless it just dropped it for 4 hours or something.
Okay.
But typically it just drops it for 30 minutes or so and it comes right back up. Anything else? All right, so AVMs. An AVM is an arteriovenous malformation. And what that is you've seen people walk around with these big purple splotches on their face. I mean, everybody's seen those people. That's an AVM. So all it is, again, at about the 4th or 6th week of fetal life that's when the arteries and the veins sort of separate. Well, if they don't separate, that's an AVM. So there's no capillaries. So normally there's an artery, and then there's capillaries, and there's a vein. And the capillaries, what happens is that the capillaries, not only do they give oxygen to the tissue that they're in, but they sort of buffer the pressure that's coming in from the artery, and so the venous pressure is way, way lower, and that's buffered by the capillaries. That's why the capillaries are there in addition to giving nutrients. So if there's no capillaries and there's no differentiation between the arteries and veins, well then this is just one pipe like that. And the arterial pressure continues in the venous side. And the veins don't have the muscle layer that an artery has. And so the pressure builds up and eventually this ruptures because the wall of the vein is just too thin. And so that nevus that you see on people's face is just a misconnection between arteries and veins. And it can happen anywhere. You can get them anywhere. But if they're in the brain itself, that's what an AVM is. Those are, again, you're born with that. It's there before you're born because it's just a non-differentiation into the capillaries. In children, that shows up with seizures because there's irritation of the brain around where that AVM is. So typically in children, the child will have a seizure for no reason, and the scan will show an AVM. They rarely have hemorrhages in children. They do have hemorrhages, but rarely do they have a hemorrhage. When they mature and you get it to adulthood, the most likely presentation is hemorrhage. It's because it's just had this time to build up. And so an adult with a hemorrhage away from the base of the brain where you would normally see an aneurysm rupture can be and likely is either a tumor or an AVM. So the difference in treatment of that is that the AVM is essentially like a tumor. It's just a big ball of blood vessels in the brain. Luckily, there's no brain inside that ball, so we can take it out like a tumor. So there's no functioning tissue inside that big ball of blood vessels. So it used to be that we would do the arteriogram, see this blood vessel, sort of map out which blood vessels are feeding it, and then make a plan about how to go in and take this thing out. The problem was that when you go in and start taking the feeder blood vessels, the change in pressure in the venous side of the AVM caused a lot of swelling in the brain while you were taking it out, and the brain would just swell up, and it was terrible. Because the brain didn't have enough chance to redirect the blood into normal veins, and the blood got stuck and just swelled up. So nowadays we embolize, that is, stop up sequentially the arteries that go to the AVM, and we typically the radiologist does that in specials. They used to use coils and silk suture and all kinds of other crazy stuff to put in there. Now they use a glue called Onyx. It's a fast-setting sort of crazy glue that they squirt in, and it sort of solidifies as it gets into the venous side. And they do that in as many little blood vessels that they can get into. Typically, we do that about 2 or 3 days before we do an operation, so that the brain has a chance to redirect all that blood that's being sort of sucked into this AVM because there's no pressure gradient. So, with an AVM, it's just this empty hole of blood, and the blood just falls into it. And if you stop that up, then the rest of the brain's not used to that pressure, and that's when it's swelled up. So the embolization sort of gives the brain some time to sort of redirect that blood and keep it from swelling. It also, when we get in and do the surgery, most of the AVM is already dead. Most of it's already stopped up. So we don't have to worry about blood loss as much as we used to. So it's made it a lot better as far as taking the AVM out. The problem with AVMs is that sometimes they're very deep. They're not right on the surface all the time. There's thousands of blood vessels that we have to kind of go around to take them out, and that's the problem with AVMs. But typically, once the AVM is out, even if it's hemorrhaged, that patient's well. I mean, that patient stays in the ICU for a day and goes out. It's not like an aneurysm. There's no spasm involved. There's no long-term effects. Once the AVM's gone, you're finished. So it's a much harder operation. It's much more dangerous in the operation, but once the operation's finished, you're done. Not like an aneurysm. Because an aneurysm, once you clip the aneurysm, that's only the first part of a marathon. I mean, that keeps it from hemorrhaging again, but all the effects of the aneurysm go out for 2 or 3 weeks. Whereas an AVM, you're pretty much done. Yeah, AVMs, I hate them.
Do you have blood pressure parameters prior to having the embolization done compared to post-embolization? Like on where you would want them to be, or does it even matter with?
Well, you don't want to get severely hypertensive and rupture, but not like the blood pressure parameters are for the spasm, and there's none of that for an AVM. So no, not specifically. There's no protocol for the AVM. We used to give them stuff called Amicar. Does anybody ever use that anymore?
I have.
So Amicar is
Not anymore.
I think I used some last night.
Amicar is it's aminocaproic acid, and what it does is it prevents hemorrhage. It sort of it's like opposite of Coumadin, but it also makes swelling. So it really didn't have the risk were way higher than the benefits, so we don't use it anymore. We used to but we don't use it anymore. They used to use it on aneurysms, and it increased spasm too, so it was a great drug. So, yeah, we don't use that anymore. Because mainly they used this when they waited for so long to operate to prevent hemorrhage, because hemorrhage was the biggest killer early, spasms the biggest killer late. But now that we operate early, we don't need that. So.
On the embolization, some people go back, like we have one dude, I think he went 3 or 4 embolizations. Is that just blocking off different veins and different arteries on the different procedures, or what are they?
It's mainly because of the size of the AVM, and there's a specific amount of contrast that you can have per session, because then your kidneys can't handle it, and you can get kidney failure if you get too much contrast. So that's why they have a amount of contrast that they can use, and once they get to that, they've got to stop and wait some time for that to flush out of the system, and then go back and do the rest of it. Depending on, it's just because the AVM's big.
What's the risk for stroke? 'Cause we had one lady in bed 7 that had embolization and came back and was completely flaccid. Is it just because they embolized like the wrong feeding?
Well, I mean, angiography is not a completely 100% safe procedure. I mean, you can get dissection of the carotid, you can get occlusion of the carotid. Depending on where the AVM is, there are arteries that actually go straight through the AVM. They look like they're going right into it, and they come right out the other side without ever doing anything to the AVM. So if it's in an eloquent area of the brain, we usually get them to test that artery. They give them some phenobarb or give them some amytal to actually put that piece of brain asleep that artery is going to see if it's going to cause a problem. And then they won't embolize that. But I mean, yeah, I mean, just like any procedure, there are complications with arteriogram. But typically, once we're in an eloquent area, we get them to test those big arteries to make sure that they can take them before they do take them.
Did we ever use the onyx for the aneurysms here? I just never have.
No, it doesn't.
I read about it and everything, but I just wondered.
It doesn't set fast enough.
Oh, really?
If in an aneurysm, the flow in an aneurysm is way faster and more turbulent than in an AVM, and so the glue doesn't have enough time to set before the blood just washes it out. They're working on some other things that set faster, but they have to again put a stent. They got to put a stent in. They put a stent, like a wire in, to hold the stuff up. So they glue the stuff so that it has a barrier so it doesn't come back down. They're working on some of that stuff. But yeah, the glue, the onyx doesn't set fast enough unless it gets washed out.
Dexamethasone for aneurysms. I mean, is that something we're going to be?
I don't think it does anything.
It's on the checklist. I mean, it's on the order sheet. I was just wondering if that's something that's going away, or you still think it helps, or what?
Steroids don't really help trauma or aneurysm ruptures unless you were to give it before it happened.
Okay.
So I don't think steroids really do anything except make your blood sugar go up, and that makes it worse for your brain. I don't think steroids really has any place. It doesn't really do anything. Unless there's some major swelling from if a spasm vessel shuts down, you have a stroke, I mean, maybe it can help some of the swelling, but I don't think it has any place preemptively in the protocol.
Dr. Megison, if someone is diagnosed with an AVM, what is the incidence of it occurring in a sibling?
AVMs are not, they're not like aneurysms. It's a random event. It's not hereditary.
Thank you.
Well, you can't say anything 100% in medicine. There are disease processes where, I think it's called Gardner syndrome or something, where you have AVMs in your gut, in your lung, and in your kidneys, and in your brain. So there's syndromes that you can have AVMs throughout. But a solitary brain AVM is not hereditary.
Thank
Yep.
Is there much correlation between like lower back pain post subarachnoid hemorrhage, or is there any validity to that?
Oh yeah, the blood sinks down in the spinal fluid. I mean, the blood, once you have a subarachnoid hemorrhage, all your spinal fluid is going to have blood in it. That's why a spinal tap is done diagnostically to see if there's blood there. And the same blood products that break down and cause spasm irritate the nerve endings, and it's really common to have back pain for a little while until that blood product breaks down. Or if you have a bad spinal tap, that'll do it. Okay?